Ultrasound-guided foam sclerotherapy is the only single intervention that can treat leg spider veins, leg blue veins, varicose veins, superficial venous reflux, and leg ulcers. Not only that, it's relatively inexpensive to deliver. It has an excellent safety profile, and the results are as good as anything else that's available, including laser, radiofrequency, cyanoacrylate, and phlebectomy. So why use anything else? Well, you have to know what you're doing. I've just come off a call with my good friend and colleague, Alastair Lewis, who sits on the board of the British Association of Sclerotherapists and who treats a wide range of vein conditions in both the north and the south of the island of Ireland. Alastair is equally skilled in endothermal ablation and ultrasound-guided foam sclerotherapy and gets equally good results from both. So how does he choose one rather than the other? And what considerations are important? Alastair emphasizes the need for a meticulous technique and attention to detail, and he describes the English method of foam sclerotherapy. He also tells us how he uses foam sclerotherapy to treat veins in other parts of the body. Here's a taster, and then we'll dive into how to get the best results from ultrasound-guided foam sclerotherapy. Be sure to check out the links to references and to Alastair's biography in the description box below. Here we go. Let's start with leg veins then. So you're an enthusiast for ultrasound-guided foam sclerotherapy. What are your criteria for treating people with superficial venous reflux and varicose veins with regard to treating them with ultrasound-guided foam sclerotherapy?
So my rationale there is I can get very similar results with either foam sclerotherapy for truncal reflux.
Tell us about the English method, Alastair.
Well, the English technique is kind of a sort of a colloquialism used by people who aren't from England to refer to the method that was originally described by Philip Coleridge-Smith and Andrew Bradbury. This is a sort of also looking all over the leg for all of the perforators, but certainly in the region of varicosities, I will be very keen to see, is there perforating vein either contributing reflux into...
One of the very few people in the UK, probably in Ireland as well, who treats hand veins, and you've sent me some photographs of before and after, which I'll share. Tell me about your approach to hand veins. Specialist now, and you are exclusively involved in the treatment of veins. You were until recently involved in the NHS, but now you have left the NHS and you're purely in private practice treating the full range of vein conditions. So give me a sense of what vein conditions you might treat then, Alastair.
The overwhelming bulk of the work is superficial venous disease. We don't have good pathways in Northern Ireland for the more complex venous disease within the NHS. We don't have any access to interventional type work in the private practice, in the private sector. So with regards to what you can do in independent practice in Northern Ireland is the treatment of either superficial venous disease or the various cosmetic things that come through, thread veins and veins on other parts of the body apart from the legs.
And let's start with leg veins then. So you're an enthusiast for ultrasound-guided foam sclerotherapy. What are your criteria for treating people with superficial venous reflux and varicose veins with regard to treating them with ultrasound-guided foam sclerotherapy?
Well, as I said, a lot of it's patient-directed, patient-choose. So if you talk about varicosities, first of all, I mean, foam sclerotherapy is the treatment of choice for smaller varicosities, more effective, certainly in my hands, more effective than phlebectomy for removing smaller varicose veins and even larger varicose veins as well. Patient satisfaction is higher with the procedure. You don't have issues with incisions, discomfort during phlebectomy with bleeding, and you don't have the longer-term issues of thread veins developing at your incision sites. So the payoff is that if you're not careful, you can run the risk of getting staining of the skin, patients that there will be an element of staining apparent in the weeks and possibly months after treatment, but it's transient and it will fade. I also tell them that if I look at someone that I treated maybe a year or two ago, I usually have a fairly good idea that I can see where I've been before, because there will be subtle signs that I pick up. But as an alternative to the more time-consuming and less popular with patients option of phlebectomy, I think those payoffs are all worth it.
And tell me about your rationale for treating superficial venous reflux.
So again, it will be, so my rationale there is I can get very similar results with either foam sclerotherapy for truncal reflux or with thermal ablation. So it comes down to a patient decision as to which option that they want to do. Financial implications are a big part of that. Another part of it would maybe be the patterns of disease that I need to treat. For someone with the simple and more common presentation of a refluxing single trunk with some varicose veins, then foam is very straightforward and can be delivered in a small number of visits. Whereas if someone has bilateral problems, maybe needs multiple trunks done in one or both legs, then thermal ablation becomes a lot more attractive even to a self-pay patient, because a single visit to an interventional room will allow you to treat all of those trunks with thermal ablation in a single setting, which you would not be able to do in a single setting with foam sclerotherapy. You then have the option of having a full 16 mils of foam at your disposal if you want to go ahead and start treating varicosities at the same time. Some patients travel a long way to see me. I have people who have made 4 or 5 hour journeys across the island of Ireland to get treatment. And particularly when you explain to them that you can turn 4 or 5 visits into 1 or 2, thermal ablation then becomes more attractive in that setting.
Yes, that's a very good point, Alastair. For those who are not familiar with you are based in Northern Ireland, but you have a practice in Belfast and Dublin. So your practice covers pretty much the whole of the island of Ireland, doesn't it, Alastair?
Yes, certainly. And the Dublin clinic is very popular. We see people from, will maybe make 4 or 5 hour journeys to travel to Dublin from the likes of Donegal or Cork or areas like that. But I also see people in the north of Ireland who have travelled from the south to get treatment there. So there's a fairly mobile bunch of patients in the island of Ireland who don't mind moving to find the best treatment or what they feel is the treatment they need.
Right, well, Alastair, you're quite unique in the sense that you feel there's a pretty much equipoise between endothermal ablation and ultrasound-guided foam sclerotherapy with regard to truncal vein reflux, with all things being equal.
Yeah, I don't think I'm too unique in that. I think if you look at the sort of published sort of results from high volume users, from people who do large numbers of patients, treat them with a well-established protocol, it's not hard to find that large case series with closure rates that are comparable to what you can see with thermal ablation.
Well, you say that, but my impression is that vein specialists are either in the endothermal camp and prefer endothermal ablation, even for a single leg and a single trunk, or they're in the ultrasound-guided foam sclerotherapy camp, and they tend to favour foam sclerotherapy for a single limb with a single trunk refluxing. But your view is that you think they're roughly equivalent, and you will let the patient decide in terms of cost or convenience. If they're insured, they may have to follow NICE guidance, and so they may be persuaded by their insurance company to perhaps favour endothermal. I think you are I think you are a little unusual. You don't think so?
I suppose a lot of people will say I'm unusual in a lot of reasons, but no, I don't think that you have to be one or the other. One of my earliest surgical trainers told me if there was two ways of doing something, they're both wrong. And he was talking about hernia repair at the time, but I think that an element of that argument can apply to truncal ablation. You can ablate trunks from sclerotherapy. That's been clearly demonstrated by a number of people. You will get failures with foam sclerotherapy and with thermal ablation in a number of patients, regardless of which method you treat them by. There's no argument with that either. So it's really down to I suppose, the small numbers of patients that maybe fall between one technique or the other. You can't be all about thermal and then have a patient who's maybe got a bit of neovascularization in the middle of the thigh after previous surgery and say, well, I can't treat that for you. I can't get a laser fiber up there. What are you going to do in that situation?
So your suggestion is that you've got to be able to call on both treatments to get good results for everybody.
Yeah, I don't think there's one single right way of doing anything. I think you can achieve excellent results with either method as long as you have an appropriate sort of sense of what you're doing, that you're doing it in a way that is repeatable, that you know that you're capable of performing, that you get good outcomes, that you know that you end up with happy patients in the long term. Either way, you need to be completely confident in what you're doing, why you're doing it, how you're doing it, and you need to follow the patients up and make sure what you're doing is working. And if it's not, then go back to the drawing board and see where you might be differing from other people's practice and why your results may not be as good as they could be.
Right. Well, I think you've touched upon an important point there, Alastair. I think maybe you will agree that with regard to the difference between endothermal ablation and ultrasound-guided foam sclerotherapy, there's more variability with ultrasound-guided foam sclerotherapy from practitioner to practitioner. I think it's reasonable to say, and I don't know if you will agree with this, that there's less variability when you're looking at endothermal ablation because the procedure is relatively well documented. But for foam sclerotherapy, there's very wide variability between practitioners, and some practitioners don't get good results with foam sclerotherapy, and some, like yourself, get very good results comparable to endothermal. You've mentioned in the past, I think, that you use the so-called English method. Tell us about the English method, Alastair.
Well, the English technique is kind of a sort of colloquialism used by people who aren't from England to describe or to refer to the method that was originally described by Philip Coleridge-Smith and Andrew Bradbury. This is a fairly robust approach to managing how to manage a patient with foam sclerotherapy. Interestingly, there's now two English techniques, because if you look at the descriptions of the techniques from both those people, from Philip and from Andrew, there's slight variations in how they have described how they do it in more recent years. Approach is, the spirit of both approaches are the same, but it's a very methodical way to manage the reflux that you are dealing with, and also to manage tributaries and varicosities, and addresses the importance of things like compression, aftercare, and then a relook to make sure that you have achieved what you aim to achieve, and that you have ablated veins where you had aimed to ablate veins, and then finally you need to follow the patient up further down the line to make sure that you're not seeing recanalization, and if you are in the early stages, you identify it and you retreat. And it's that approach, the methodical approach of identifying reflux where it needs to be dealt with, identifying tributaries that are going to cause your truncal foam to fail, to make sure they're treated as well. Treating larger varicosities again that will empty blood into a trunk that you hope that you've put active foam into. You don't want that being destroyed by blood emptying in from varicosities or other tributaries. If you go through all of those steps, you can then find you will find that you will get the sort of results that have been described by Andrew Bradbury, by Philip Colby-Smith, and by other authors across the world.
Tell me about this this photograph that we're looking at, Alastair. We can see a picture of the medial aspect of this gentleman's right leg, and he's got visible varicosities and some discoloration and an ankle flare.
This is a patient who has, it doesn't come out quite well in the photograph. There was quite a bit of hemosiderin deposition around the ankle as well. And is very symptomatic with itch, concerned about ulceration, family history of venous disease, as you know, a lot of these patients will have. The varicosities don't come out particularly well in the middle third of the calf in this particular photograph, but they were the source of a lot of throbbing, aching, and heaviness during this chap had short saphenous reflux in a vein that measured 4 millimeters. The great saphenous reflux in a vein that varied between 6 and 8. The varicosities were mainly confined to the medial aspect of the right calf, and then there's a lot of signs more peripherally of the corona of the ankle, thread veins in the region of a perforator, and hemosiderin just above the medial malleolus. Doesn't really come out particularly well in the picture.
So, just to be clear, Alastair, are you saying that in that photograph the gentleman has small saphenous reflux?
Yeah, he had small saphenous reflux and great saphenous reflux. Small saphenous reflux
and great.
And great, both filling into varicosities in the medial calf.
And he had an incompetent perforator above the ankle. And you treated the great saphenous vein, the small saphenous vein, and the incompetent perforator with ultrasound-guided foam sclerotherapy. Is that correct, Alastair?
Yes, that and his the varicosities would have been injected as well.
Right. And you've sent me a photograph of what his leg looks like afterwards, have you? Yes, 6 weeks. That looks a lot better. Better.
So at 6 weeks, you can see there's been marked improvement. You can see a bit of bruising and staining where the worst of the varicosities are present. There's been a marked improvement in a lot of the small vessel change in the corona and the other small reticular veins and thread veins in the area, which were not injected directly. They were, I presume, some foam had filled off the varicosities via reticular veins, and he must have ended up with a bit of foam in those vessels. At a 6-month review, he had a few areas of trapped blood in the region of the varicosities. You can sort of see and appreciate the staining in the posterior aspect of the calf. And the only thing that was done at that visit was some aspiration of trapped blood under local anaesthetic.
So, just to summarise that, Alastair, those 3 photographs that you've shown us, the before, the 6-week and the 6-month, that was one session of foam sclerotherapy, was it, Alastair?
He's had a single set of treatments. He should have been back to see me at 2 weeks, but it was 6 weeks before he returned to that appointment.
Right.
He didn't do any further injecting at that stage. at the 2-week appointment, I would normally be, or well, the first follow-up appointment, I would be looking very carefully at all of the veins that I have put foam into, to see, can I see any signs of patency within the vein, any signs of intact endothelium on ultrasound, or am I just looking at either well organised thrombus or more liquid thrombus, which is darker in ultrasound, and I'm looking at the varicosities to see. Quite often you'll find that with the varicosities that when you fill them with foam on the day and you cannot see any residual varicosities, I like to describe it to patients that you want to be looking at, you want the ultrasound picture to look like the stars have come out at night after the foam's gone in, so you don't see any of the black circles that were present on screen beforehand. You sort of see lots of little white specks of veins in spasm as you move the probe around. Quite often you'll find that some veins that weren't evident at the end of the procedure either did not quite have an adequate amount of foam in them, or were just in spasm because in response to the other things that were going on in the leg. So if you find any varicosities that have recurred or survived that initial episode, then I'll re-inject those at that time. This chap did not. The only thing he had done at his 6-week review was some aspirations of trapped blood in the region of the larger varicosities.
So one treatment at one visit, one session of treatment involving the GSV, the SSV and the tributaries in one visit, and he required no further intervention. And at 6 months, presumably everything was occluded and there was no reflux.
For the 6 months, yeah, there was a bit of the chronic venous change is a bit more obvious. You could see a few little thread veins that weren't as obvious at the first visit, and a little bit of staining that was still present but resolving. But by and large, again, there was no further treatment done at that stage. There was no aspirations required at that stage. So that this is one chap that has had everything achieved with a single treatment session, single follow-up session, and a 6-month review was fine. There was nothing further to do.
Excellent. He must be very pleased with that. Well, he must have been very pleased with it.
Well, he was very pleased. He was very happy. The biggest thing for him was his symptoms. He was happy that I was able to tell him that his reflux his truncal reflux had been dealt with satisfactorily. And one of his concerns was the fact that he had family members with venous ulceration. They've gone a long way to greatly reducing your risk of developing venous ulcer. He knows that he has venous disease, as all my patients do. I get told that this episode has been dealt with, but venous disease is a chronic condition. Every vein in your body has the propensity, under the right circumstances, to become varicose, and I see people come back in the future. He's been advised to wear compression in an effort to mitigate against that, pick him up again in a few years' time, further down the line.
Right, excellent. Okay, so this is an example of a good outcome, which is quite typical in your practice.
The final outcome was typical. The fact that he got there with a single treatment session without further treatment is common to some patients, but one of the things that you have to be ready to do if you're a treating patient with foam sclerotherapy is to be very meticulous at the follow-up visits to see if there's any areas that have maybe not responded completely to treatment, and then you can address those with a further injection of foam if required.
Okay, so okay, let's delve in detail then into this so-called English method that you use. Let me summarise it from my point of view, and let's see if I understand the English method correctly. So, they get a full duplex, and you would look from the groin down to the ankle, In this case, for example, you've just described, you've identified reflux in the great saphenous vein and the small saphenous vein, and you've identified a perforating vein. And in this case that you've described, you've been able to close the GSV, the SSV, the great saphenous vein, the small saphenous vein, and the perforator, and you've dealt with the tributaries in one visit, which is excellent. So do you scan for perforators systematically, or do you come across them when you're examining the truncal veins and the tributaries? Do you go hunting for perforators?
I will go, I'll tell you what I approach the scan. I will start proximally and I will work distally. I will look at the sphenofermal junction, great saphenous and anterior accessory veins initially, and then I'll proceed peripherally, looking down the full length of the great saphenous to the ankle. The one area where perforators tend to be clinically relevant, I find is distally in the medial leg in the great saphenous. I will look at the short saphenous vein, and then I will look at the varicosities themselves and trace the varicosities back to wherever they are, wherever they're feeding into the deep system or into the main trunk, and get a general feel of, then get not only the underlying, which vessels are refluxing, which are causing problems, but also what directly is filling the varicosities that you're seeing. Because quite often they can be coming from perforators up directly off a main trunk. So that's I don't go looking all over the leg for all of the perforators, but certainly in the region of varicosities, I will be very keen to see, is there a perforating vein either contributing reflux into into a network of varicosities, and where are the varicosities draining back in more peripherally? And again, that's quite often from a perforator or via a perforator into the deep system.
You don't specifically go hunting for perforators?
I will in the region of where varicosities are present, but I don't look at all of the perforators in the leg. So I want to see where where varicose veins are receiving refluxing blood from, where it is where it's ultimately emptying back into the deep system, and quite often perforating veins can be the source and the emptying of a particularly net.
Okay. So do you when you come to treat the veins, do you deliberately treat the perforator veins, or do you treat the varicosities and the truncal veins in the region of a perforator? By which I mean, do you actually try to get a needle and deposit foam into a perforator?
No, I'll treat, well, I will if there's if you've got an isolated group of varicosities that are arising from a perforating vessel. If you've got or in patients with C5, C6 disease, where the perforators have been very much a probable source of the initial pathology. The majority of patients I treat will have early grade 2 disease, and the one thing that would drive me to tackle a perforator directly in that group of patients is if a perforator is very obviously a very obvious source of reflux into a particular patch of varicosities. For the majority of those patients, if you treat truncal reflux and if you treat the varicose veins completely inadequately, the perforator that you saw was quite often the exit point from those varicosities back into the deep system, and it will resolve in the rest of the time.
Good. Yeah, that's good. Okay, so the English method. Is it fair to say that the English method involves multiple cannulae along the length of the truncal vein? So, for example, if it's the GSV, it might be 2 cannula above the knee for the GSV and say 2 or 3 cannula below the knee for a GSV?
Yeah.
And
Yeah,
is it fair? Say again.
I'll usually have 5 cannulas in throughout the length of the GSV from top to bottom, to treat the whole thing. I don't think you can do it adequately with less than that.
Right. And for the SSV, it would be 2 or 3 cannulas? 2 cannulas?
1 or 2. It depends on the length of the vein that you need to treat.
Okay.
Quite often, I find a lot of short saphenous veins become normal quite quickly. So we're quite often dealing with 5 centimeters, sometimes less, of actual trunk that needs treated before the varicosities arise. So yeah, 1 or 2.
1 or 2. Okay. So cannulas along the length of the trunk. Then you would put small, short cannulas, perhaps of butterfly, into the tributaries as marked.
Yeah,
that's correct.
Either butterflies, or I quite like using the blue venflons, 22 gauge venflons. If you've got a sizable varicosity, you've got a much shorter that you're giving your foam down. That's one of the small details that's important in achieving good results. Butterflies, it's hard to get butterflies with very short tubing. I find that a lot of the butterflies that I'm buying have maybe 20 centimeters of tube on the end, so that's a lot of foam to travel through the tubing before it gets to the butterfly, to the vein, and then if you're giving foam in smaller volumes and by smaller repeated injections rather than a single one, and you've got a dead space of 0.5 ml, as a lot of these butterflies do, then you're losing valuable active foam. The other thing that butterfly can do is, if you're positioning the patient, moving the patient with the sharp needle, is it can sometimes cut out of the vein, and then you end up giving your foam sort of perivenous rather than intravenous, so it has no effect.
Right.
So
okay.
These cannulas.
Yes, and you've kindly sent me a photograph of a leg, the small saphenous, with lots of cannulas in. So I'll share that during the course of the interview as well. And so multiple cannulas, whether they be long ones in the saphenous trunks and then shorter ones in the tributaries, and then another important part of the English method is to empty the leg of blood as much as possible by elevation. Is that correct?
Yeah, so elevate the leg and flush the catheters, and you're doing 2 things there. You're ensuring that you've got good patency of the vessels, nothing's happened when you've elevated the leg, and the concept comes from George Fagan's practice, is to try and get blood out of the vein, and as much as possible reduces the work that the foam has to do to become before it's effective.
Yes, and of course foam is inactivated by blood as well, so that's another important aspect. And what do you flush it with? Saline?
I use saline. I know a lot of people use tumescence fluid. The additional adrenaline is felt to maybe add a bit of vasospasm to the vein and reduce further the amount of the amount of blood in the vein. But I'm flushing the cannula with like a couple of mils of saline immediately before I inject the foam. Saline's at room temperature. It's going in just a bit of vasospasm, just even by the thermal effect.
Vasoconstriction. And then you will inject the foam. What's your sclerosant of choice, Alastair? Is it polydocanol or?
No, I use STS. When I learned to do foam sclerotherapy, I learned in the south of Ireland where polydocanol was the agent of choice. But then this was almost 20 years ago now, when I started practicing the north of Ireland in the UK. You could not get sclerotherapy, so I had to. Well, I switched to STS, and I've been using it ever since. Now you can get polydocanol, but I've been my practice has got where it is with STS, and I don't want to change anything.
All right, good. And what percentage strength of STS do you use for the trunks and the tributaries?
So with tributaries, when I'm talking to people about foam sclerotherapy, people ask me about what I do or how I do it. I'm always telling them that if you use half the strength that you think you need and you have twice the number of cannulas in, you're probably getting close to the ideal. So for tributaries, I would be using 0.2 or 0.5, just depending on the size. And that's really pretty much all tributaries. Anything that's sort of above the fascia, I'm reluctant to use anything stronger than 0.5. If it's a big vein, I might use 1%, but you do get more staining and you do get more of a phlebitic response afterwards. With the great saphenous vein below the knee, depending on the size, depending on how the vein wall looks, I'll either use 0.5% or 1%. Short saphenous vein, similarly, 0.5%, 0.1%. For the above knee great saphenous vein, I only use 3% there. I used to use 1% selectively, but then I was seeing recurrences, and I just thought, well, that's added a visit onto the patient's experience. It's taken an appointment out of my earnings potential. So I don't want patients coming back with open veins when they don't need to. So I just use 3% now, regardless of what the great saphenous vein looks like.
Right, so 3% above the knee, 1% or 0.5% below the knee, and 0.5 or 0.2 for tributaries. Is that right, Alastair?
Yeah, that's about
it. Yeah, that's right. Okay. And you've kindly shared your system for elevating the leg, and you've kindly shared your bandaging technique. Do you use eccentric compression afterwards? Do you put any pads, or you just go straight to a non-stretch, non-elastic bandage?
The majority of patients is simple concentric compression with a short stretch bandage underneath the stocking.
Right.
The patients with large varicosities, so varicosities of 8 millimeters or 10 millimeters or greater, I will use eccentric compression on those. Usually, my concern about eccentric compression is that as you up the compression level, and particularly with sponges and pads underneath bandaging, then you run the risk of having compression-related complications afterwards. So what I tend to use are the little foam pads, but between the layers of PA bandaging rather than directly in the skin with the bandage on top. And I find that's meant that I'm not seeing the issues that I did initially with injury to the skin, either blisters or signs of shearing underneath the compression bandage itself when it came off.
Do you bandage above the knee, Alastair?
Yes, so I'll bandage above the knee and below the knee, but not across the knee, and I leave the knee free to allow the patient to mobilise properly. And again, it's that bandaging that does determine where your cannulas go in the great saphenous vein, because ideally you want to have compression on the site of access, so that when you take your cannulas out and you can get compression over the sites of access, then it prevents the risk of having the patient having a bleed on their way out of the clinic.
Right. And what strength stocking do you put on? What's the compression strength of the stocking?
The majority are European class 2.
Right.
Over the top of the short stretch bandage.
And day and night for how long?
Day and night for 7 days. Then the patient can take off the bandage underneath the stocking, have a shower, breathe a sigh of relief. And then for the second week, then the stocking on its own daytime only.
Okay, right. Well, your results are excellent, so I can't make any comments about your regime. It's excellent, very, very good indeed. And that's the English method.
That's the English method, which is
Great.
very well described.
Yes.
A number of people. So
Yes. You've sent me the references, and I'll put a link in the description box, Alastair. Thank you very much. Now, tell me, how are you making your foam?
I am using, so in the north, I'm still making my own foam. I'm in the process of acquiring my own Varixio device. So I use the little 5-micron filter. Syringe choice is paramount. And then whether you use a filter, whether you use a three-way tap, the standard Tessari method with air will give you an effective foam. In the south, I have access to Varixio, which I am using more. I've only started using it recently, and I'm starting to use it more and more. But I've been very impressed with that device on a number of fronts. First of all, if you're working single-handed, and you have before I start the cannulas in, I set the machine off with my foam in it. At the time the cannulas are in, the Varixio machine has made the foam. It's sitting there ready to go. It's a bit like when Chris Pittman was talking about having the foam barista. I don't have the luxury of my own foam barista, but the Varixio machine provides that function quite nicely. The other thing that really quite interested to see with Varixio is the impact of the foam that it makes on the outcome of the treatment. And that's something I'm going to look forward to seeing, not only in my own practice, but when people start to compare it to physician compounded foam. We saw that with Varicina, and when it came out, it appeared to be better at closing veins than physician compounded foam. And it looks like what evidence is there at the minute for Varixio is that a similar effect's going to be noted when it's done, when those trials start to emerge.
So from your point of view, you like the Varixio because if you're single-handed, it allows you to prepare the foam whilst you're placing the cannula, and it gives you a more efficient throughput.
Yeah, it improves that, but the quality of foam is better, by all accounts. I was interested on Mark Whiteley's comment on your about Varixio and reticular veins and thread veins, and certainly he's found that I have not used it in that setting, but I will be the first opportunity. But he's sort of find that the better quality foam is definitely working better in patients, at least from a subjective point of view.
Good. Okay. Well, I look forward to hearing how you get on with Varixio, but you've adopted it anyway, and you're liking it.
Yeah, I'm in the process of going full Varixio at the minute, but I'm at an early point of that journey. My days of syringes and filters and then squirting foam at people, which you do at least once a day. Usually myself. Somebody always gets covered somewhere when they, particularly if you're making up multiple amounts in the middle of treating a patient, you get a bit of the syringes become a bit moist in the tips. You nearly always find somewhere that will fly apart. Someone gets some foam in their shirt.
Usually you. Right, before we leave the legs, Alastair, tell me, there's one more thing I wanted to ask you. What it is? Oh, yes, I know. Tell me, before we leave the legs, is there any size of vein that you think, well, I don't think foam is the right treatment for this leg? The GSV is of a certain size. I would prefer endothermal. Or all things being equal, is the size of the vein not a consideration for you?
The largest varicosity that I've treated recently, and the patient is during his treatment course, was almost 5 centimeters in diameter. So, and in the proximal leg. So with that in mind, I suppose the answer is no. There's no vein I won't tackle with foam. as long as the patient's on board. This chap's quite an interesting fellow. He was a competitive scrambler for years, was essentially giving himself a first-degree burn at the top of his left leg every weekend because the exhaust of the motorbikes that these guys race around fields and over jumps and things, actually your leg touches it. And because he was obsessed, he'd be racing for 6 and 7 hours a day when most people would normally do 1 or 2. So he's constantly burning the top of his thigh. And at that site, he then presented many years later to me with a varicosity that's just under 5 centimeters in diameter. It didn't fit on I couldn't get a shot of it on my ultrasound probe because it was wider than the field of view of the ultrasound I had at the time. So I had a chat with him and said, we've got issues here because this is at the top of your leg. It's going to be very hard to compress. It's very large. You're thin. And we've got a couple of options. And I was quite honest with him and said, I have not treated a vein in this area of this size. So I gave him sort of the options of foam sclerotherapy to destroy the vein, explain that we are going to have thrombus in that. We're going to turn it into a hard lump. I've seen 3 centimetre, 4 centimetre varicosities more peripherally disappear completely over a prolonged period of time, around maybe 6 months. But I've seen those disappear completely. But I don't know if it's going to happen up here in this bigger vein at the top of your leg. So I've talked through foam sclerotherapy as it would do. I could ligate it for you and just under anesthetic, size it and move it that way. But he really didn't want. He came to see me because he didn't want to have an invasive procedure. So we talked through the various options, and I said I've spoken to a few people who will have undoubtedly have treated a vein like this with foam sclerotherapy and take their advice and their outcome. So I contacted Philip Smith, who's well known for his foam practice across the world, and we discussed it, and Philip gave me a protocol to try this, do this. And I presented it to the patient, so he was quite happy to go ahead. So he's been treated. He's had a couple of visits for aspirations to retained blood. The varicosity is now 4 months post-injection. It's probably about half the size it was. The patient's very happy with how it's progressing. He's expecting it to take a lot longer to settle, and we both have accepted that worst case scenario that I might end up incising the varicosity under local anaesthetic with a small scalpel and expressing some of the anaesthetic blood that way if required. So we're looking forward to seeing him in the next few months' time, and if anybody wants to come to the BAS meeting next year, I suspect his course will be discussed or presented and discussed at that meeting. It'll be or somewhere, possibly the Venous Forum. He's been very good at serial photographs, allowing me to take serial photographs and detailed ultrasounds, or more detailed ultrasounds than normal, and it's quite happy for him to be presented to the Venous Forums when the time comes.
Great. And tell me, with regard to the GSV, some people have suggested that 8 millimeters, 9 millimeters is the upper limit of effective treatment for foam sclerotherapy. What's your experience, Alastair?
No, you can treat trunks diameters greater than that effectively. You will need to treat you will probably need to treat them more than once to get closed successfully. The failure rate or the recanalization rate. Failure is the wrong term, I should say, but recanalization rate is a little bit higher than it would be for smaller veins. But recanalization of a great saphenous vein is not a treatment failure in its own right. Recurrence of veins and recurrence of symptoms are. And I think that's an important distinction to make. And it's part of the ethos of foam sclerotherapy is that you're treating patients. You're not treating ultrasound scans. You're not treating veins with Latin names. The patient is the person that's receiving treatment, and the decision as to whether treatment's been successful or not belongs to the patient. And when patients come back to see you again, sometimes 2 years, sometimes 5 years, or whenever down the line they're back because there's something they want you to have a look at. And that's all my patients know that I see my patients again at some point in the future, and that they will be not offering them lifetime freedom from venous disease with a single episode of treatment of their veins somewhere along their life journey. So that I think that's one of the things that when you come into treating the bigger veins or larger caliber veins, that you just have to be cognizant of.
So you don't have any upper limit for the size of GSV or SSV?
No.
No.
I will certainly treat anything. Now, I will be telling patients with the very big veins or a very long length of, even like a 1 centimetre vein or 12 millimetre vein right down to the ankle. I will be clear with them that that's a patient that I would be saying better off having your main trunk treated with thermal ablation for these reasons. But if you want to have foam sclerotherapy, we can go down that route for you. You will need to come and see me more often. Your risk of failure is higher. The durability of your treatment may not be as good as it was if the vein was half the size it is. But we can do that for you. And if you want to heal an ulcer or relieve symptoms, you can do that effectively. If the patient's happy that and accepts that the outcome may not be as durable, then there's no reason why not to do it.
Excellent. So I think we've covered leg veins, Alastair. Is there anything else you want to add to the application of ultrasound-guided foam sclerotherapy to the treatment of leg veins?
The one other area I would use it a lot is with reticular veins as part of microsclerotherapy. Patients that I see are thread vein patients. Nearly all of the thread vein patients that you come across will have reticular veins that are feeding it. I've got access to 18 megahertz ultrasound, which is an excellent way of seeing veins that prior to that you would have maybe would not have believed existed. And if I can get a 25 gauge butterfly into a reticular vein, then I will almost certainly put some foam down it. Currently, I'm putting 0.1 or 0.2% handmade STS foam down. And it's that group of patients I'm particularly keen to see now they've got access to Varixio, what sort of difference it makes.
Yeah, excellent. And I just wanted to very briefly touch on hand veins, Alastair, because as far as I'm aware, you're one of the very few people in the UK, probably in Ireland as well, who treats hand veins. And you've sent me some photographs of before and after, which I'll share. Tell me about your approach to hand veins.
We first talked about this maybe 4 or 5 years ago, because I think my approach differs quite a bit from your approach when you were treating them. The first thing, I suppose, is with all veins patients, there's expectation management. I find that the patients with veins, or are concerned about the veins in the back of their hands, are probably more demanding than patients with cosmetic veins in their legs. And I suppose that's for a number of reasons. Your hands are constantly on display. Patients with hand veins, with the presence of hand veins, is very aging in the eyes of the patients who have them. And the other thing that, from that point of view, is that they need to understand that the hand veins they can see are normal veins. They've always been there. They've always looked like that. And the thing that's actually changing is the skin. And whilst I can treat the veins quite effectively with foam sclerotherapy, treating the veins will not cover up the tendons. It will not cover up the amount of discolorations or blotching or anything that also acquired with age and the wrinkling of the skin. So you need to be careful that the patient's going to be happy with that, because sometimes they're not. But and you also need to be happy that they know that I'm quite happy to treat veins in the dorsum of the hand, but not anywhere else, not anywhere more proximally in the forearm itself. And if they're on board with all of that, then I'll embark on treatment for them. Treatment itself, I treat with usually 0.2% STS foam. I'll place a number of butterfly cannulas in the veins. I will apply distal pressure to the vein and fill it with foam, and then keep the distal pressure on for maybe 10 seconds or so, and allow the foam time and contact with the endothelium of the vein. And do that usually at 2 or 3 injection points in the back of the hand, and then maybe repeat the injection with again the distal pressure to allow the vein to fill with foam, and that foam to sit in contact with the vein wall for as long as possible. Treat both hands, and then I will usually put a P.5 bandage with some dental roll for a bit of extra compression in the dorsum of the vein, just for 24 hours or 48 hours, and then I'll give the patient a compression gauntlet to wear in conjunction with the P.5 bandage for 2 weeks, and then to continue to wear once they've taken the bandage off themselves. I'll then see the patient usually about 2 to 4 weeks following treatment. And you'd be surprised how little retained thrombus you have to deal with. There's always some, but it's not as much as you would have imagined. And then there's usually some of the veins, certainly some of the larger veins, that require a second treatment at that stage. So I find hand vein patients quite often will have maybe 2-3 treatment sessions in total to ablate everything to their satisfaction. I always do say, before and after photographs are great. So look how much the improvements been. Your hands look normal. You can have more treatment if you want, but it's still more complicated. Again. But they always want done. They always want all of the veins totally on top of any sort of visible blue at the end.
Are there any other areas of the body that you treat, Alastair?
I treat, similar to the hand veins, there's veins in the chest would be quite common. Again, not just in the older age groups, but sort of the décolletage area. Again, quite often it's normal reticular veins that are becoming prominent just with the effects of the aging process of the skin. I treat the small red veins on the face, but not with sclerotherapy. I use short-wave diathermy for those.
Great. Alastair, you've been very generous with your time. Thank you very, very much. No, it's been delight. And you're on the board of the British Association of Sclerotherapists. You've been on the board for 4 or 5 years now.
For about 2 years now.
2 years. And for those who are watching this video, there's the annual meeting every May. We've just had one. And as you alluded to, there's a meeting next May where we have interesting cases to discuss and more tricks and tips. And I look forward to hearing about your experiences with Varixio.
Very good. Yeah, I'll be looking forward to sharing those.
Great. Thank you very much, Alastair.